Hello everyone, thank you for joining me. My name is Dr. Vivian Mumbiro, and it's an honor for me to present to you my abstract titled "Is the recommended Valganciclovir dose adequate for empirical treatment of CMV pneumonia in infants living with HIV in sub-Saharan Africa?" This was a pharmacokinetic sub-study that was conducted within the EMPIRICAL clinical trial. The current WHO guidelines recommend treating severe pneumonia in infants living with HIV with empirical treatment against pneumocystis jirovecii, strep pneumonia, and Haemophilus influenza. CMV, however, remains a very important but neglected cause of morbidity and mortality within this population. So CMV is a very common infection that affects people of all ages, but in children and infants who are immunocompromised, it could cause very severe disease like hepatitis and severe pneumonia in this case. Valganciclovir is a drug that is used for treatment of CMV infections in immunocompromised hosts. It's actually an oral prodrug of the active metabolite ganciclovir, but unfortunately there is no pharmacokinetic data that is available on use of valganciclovir in infants living with HIV currently. So what was the purpose of this study? The purpose of this study was to determine exposure and sources of pharmacokinetic variability of ganciclovir in infants living with HIV who also have severe pneumonia when it is administered orally at the current recommended dose of 16 milligrams per kg per dose twice daily. This PK sub-study was conducted within EMPIRICAL clinical trial for the treatment of severe pneumonia in infants living with HIV. EMPIRICAL clinical trial is a multi-center, randomized, factorial, open-label clinical trial whereby participants are enrolled and randomized to either one of four arms. The first arm being your standard of care arm, where they receive their high-dose cotrimoxazole, prednisolone, and the conventional antibiotics for community-acquired pneumonia. The second arm being a standard of care plus TB treatment. The third arm, standard of care plus treatment against CMV or valganciclovir. And the fourth arm being standard of care plus TB treatment and valganciclovir for treatment against CMV. So 85 participants were recruited from hospitals in Zimbabwe, Zambia, Mozambique, and Uganda between August 2020 and August 2022. These were 85 participants from the EMPIRICAL cohort that had been randomized to receive valganciclovir for treatment of CMV pneumonia. Valganciclovir reconstituted syrup was given to these participants at a dose of 16 milligrams per kg per dose every 12 hours. And PK sampling was done at 2 hours and at 5 hours post-administration of valganciclovir on day 3 of enrollment into the clinical trial. And at day 3, every participant was guaranteed to have received at least 3 doses of valganciclovir. Ganciclovir area under the curve for a 12-hour dosing interval was estimated using a limited sampling equation. The geometric mean area under the curve and proportion of subjects within the PK target for CMV treatment were determined. And this target for CMV treatment is 40 to 60 milligrams per liter. So now coming to the results, the geometric mean area under the curve was 38.9 milligrams per liter, Only 30% of the 85 recruited participants had an area under the curve within the predefined efficacy target for CMV treatment. The remaining subjects were either below or above the target of 40 to 60 milligrams per liter. There was a positive correlation between area under the curve and weight for height Z-score, and there was a negative correlation between area under the curve and age, area under the curve and estimated glomerular filtration rate, and area under the curve and body surface area. And in this slide is a graph showing distribution of exposure to Valganciclovir for our participants, with only 35% of them being within the predefined target for CMV treatment of 40 to 60 milligrams per liter, and 18% being achieving exposure above target, and 47% achieving exposure below the target. In conclusion, a significant number of our participants did not achieve the PK target for CMV treatment when receiving Valganciclovir at the current recommended dose of 16 milligrams per kg per dose twice daily. Exposure to Valganciclovir decreased with increasing age, body surface area, eGFR, and with poorer nutritional status. Our findings are consistent with other PK studies in transplant infants receiving a similar dose. These targets are, however, based on post-transplant adult targets and may not necessarily apply to our population, which is this population of infants living with HIV. Relationship with efficacy is yet to be investigated in the EMPIRICAL clinical trial, as we await data on virological and clinical outcomes of these participants. I would like to thank all stakeholders involved and all the parents who consented to have their children enrolled into this sub-study. Without these people, none of this would have been possible. Thank you very much, Tatenda.